Recording is going. Thank you very much for joining week 4 of the TriNetX Summer Boot Camp, where we'll be talking about conducting outcome analyses. This is probably the most important. It's definitely some of the stuff we're going to cover today is some of the most valuable stuff that TriNetX can do for supporting researchers. So we are going to be going through this piece by piece, backtracking a little bit to cover some of what we discussed last week, and then moving forward again to look at some of the additional features in the outcomes analysis components in TriNetX. Great. So, as you'll see, we are in week 4 of 6, so we're just past the hump and moving in towards the end. Next week, we're going to talk about Cox proportional hazards models and treatment pathways. It's going to be a slightly shorter session just because these two tools have very specific use cases. And then in week 6, we're going to talk about posters, manuscripts, and writing tools, and AI, and other components that we've developed to help support our students and researchers. Um, we're moving through our our objectives to discuss propensity score matching again, and we're going to continue on with navigating TriNetX. As we've talked about before, week 4, we're now building our house in my clumsy metaphor of our foundations and houses. Last week, we talked about propensity score matching and choosing an analysis tool, and this week, we're going to talk about stats. Um, if you're following along in the rapid development process, you will be generating initial outcomes and rebuilding cohorts if needed. And in the even more rapid process, you'll be examining your outcomes and checking with an expert to determine how well things are going. Again, my clumsy foundation of your study would look something like that we covered in the past. Having really strong inclusion and exclusion criteria, time, order, and frequency of events, and cohort exploration for confounders. Those would be things you're going to want to have really solid before you start running analyses. I hear this all the time from students who are like, well, I'll just get in there and I'll play with it. Don't. Having a really solid analysis plan that's really fleshed out, connected to the literature, and really well defined is essential for having any kind of result worth reporting using the tools we're going to describe today. And all of that supports your outcomes, right? The analysis type, having the correct analysis type, cause and effect order being defined properly, and propensity score matching being well done is going to be really important for that. Um, Again, you can follow along if you want to look at the study from the Journal of Alzheimer's Disease that we developed in the past. Sorry, one sec. Um, it is based on this Instagram clownery, some guy who claims to be a famous an authority in nutrition, got up on the internet and spouted off about how statins are caused by Alzheimer's, or sorry, that Alzheimer's is caused by statins, which makes no sense because that none of the claims he makes are real or valid and all that kind of stuff. So I wrote a whole paper with a team of medical students to explore this question, the question of whether in a real world data cohort, patients who are prescribed statins are at higher risk of Alzheimer's than those who are not. The answer is no. They are actually at lower risk, and our data comports with other meta-analyses of observational studies. So that would indicate that there's some evidence to indicate that this is not a thing we should be afraid of. So, it is obviously a valid question. Maybe fewer people should be on statins, right? Maybe we're overprescribing the drug. And just when I first started working on the study in 2024, there in fact was a study that came out that indicates that maybe we are overprescribing statins as well. And that's an important clinical question that has to be resolved. Maybe the people who need it aren't getting the drugs early enough, and people who don't really need it and don't fit the profile, maybe the profile was too loose and they were just putting people on it. So it's a valid clinical question. However, this is Instagram clownery. So please, be on the lookout for things that are falsifiable like this. As I said before, in past versions for Alzheimer's, it's really complicated, right? Statin dosage, length of treatment, comorbidities, dietary considerations, poor understanding of Alzheimer's underlying causes, right? Whether it's type 3 diabetes, right? Like caused by persistent inflammation in different cells could be part of it, all sorts of stuff like that. And there's genetic and issues as well. And again, as I pointed out in the past, ethical issues. If statins help with triglycerides and prevent really serious cardiovascular morbidity, is it ethical to withhold them to protect against Alzheimer's? That's something that you really can't answer with TriNetX. But actually, some of this stuff is answerable in using data. So, as I pointed out in the past, recent meta-analyses had uh, looked at this very issue and found that people on statins were at a 32% reduced risk of Alzheimer's, and that's pretty much in line with what we found in our TriNetX analysis as well. So there's some support for that. And the efficacy of statins in the treatment of Alzheimer's disease. In this one, this was the one on the left is a meta-analysis of observational studies. The one on the right is a meta-analysis of randomized control trials. However, the randomized control trials found no difference in people on statins versus not, and outcomes for Alzheimer's. However, there's a lot of methodological reasons that that could be the case, due, for example, to the fact that randomized control trials are typically, Alzheimer's isn't one of the endpoint studies. It's a very long prodromal phase with multiple years where people's memory and functionality decline. So it can be very difficult to track them within the confines of a randomized control trial, which typically go for, 1 to 2 years with a maximum of 3 to 5 years in some cases. They're very expensive, so you usually don't use them to look at things like Alzheimer's and dementia unless you're looking at immediate short-term benefits like clearing plaques and things like that. So observational studies may be argued to give a better window into this because you can see what happens to people over time. And we make trade-offs in these, right? We don't get randomized assignment in observational studies, but we do get we'll call it more naturalistic data based on people's actual real life situations. So those are just some things to think about as you're understanding that there's no such thing as a perfect research methodology. There are ones that are stronger for certain questions than others. But our hypotheses were things like is statin use is not associated with any changes in likelihood of developing Alzheimer's disease. That's our null hypothesis. But statin use is associated with a lower likelihood of developing Alzheimer's disease. That's basically what we found when we looked at the existing literature that would support it. Not that, as that person claimed on Instagram, it would make things worse. Time on treatment impacts likelihood of developing AD, and that's something that we were able to test with TriNetX as well. And dosage impacts likelihood of developing AD. We also looked at type of hydrophilic and lipophilic statins. One is much more powerful at lower dosages and is used, for example, post-stroke. That's the hydrophilic because this is the blood-brain barrier and how it crosses over more effectively to manage cholesterol and the kind of fundamental components that turn into blockages in people's small blood vessels in their brains. So those are some of the things that we looked at when, I used to talk more about this study prospectively, but now it actually exists. It's out there. You can go read it. If you read it, we want it to be comprehensive in our understanding of the limitations of this. I think we have like 9 limitations, right? Our cohorts reflect patients engaged with healthcare systems connected to TriNetX, although we implemented new user strategy and verified the absence of immortal time patterns, blah, blah, blah. Like we really tried to think about all the limitations that we had in our study. And I encourage you to do the same as you're developing your analyses. Last week, though, let's do a quick revision of what we talked about in the last video, which you'll find on YouTube. We talked about the characteristics window. This is from the day that your study begins, that somebody first enters your study. The characteristics window, and you can see here it's over in the left-hand side of your analysis tool, of your compare outcomes analytics tool. Let me just show you where you might find that in your TriNetX study. If you're under analytics and you would open up one of your analyses, you would be able to see it right here under characteristics. So it says analytics up top and then cohorts. That's where you get to set your specific cohorts that you're going to be analyzing. And the characteristics is where you can set the starting points for your index event by checking these boxes and also specifying your look back period. Again, to just describe why this is important, if you are interested in people who have had chickenpox in the last 5 years, you could set your timeline to look back from the start of your study, the first day people enter your analysis, to 5 years previously. You can specify how far back into the person's health record you want to look for events that are going to be part of your propensity score matching and part of your cohort definition. Again, this is I'm dating myself, but from the movie Back to the Future, this is your DeLorean going back to the year 1955 to get into the past, right? And you can see there again, the reason you can remember this is the same day, the day your study starts, is on the far right-hand side of this timeline, looking back, to the left to any time in the past. So that's just how you're going to use the characteristics window. And again, to review the concept of an index event into the past relative to what, right? So TriNetX defines an index event for each cohort, and it's the first date for each patient within a cohort that they meet all the selected criteria for that cohort. So here you would see that depending on the boxes you check, people enter in when these events have occurred or these events have occurred. And that becomes the date that this look back window starts from. And it also, as we'll find out, is the date that the look forward window starts from as well. But that's what an index event is. It's essentially the starting point for any given participant in your study or record in your study. TriNetX has a really good example that we went through last time, and I recommend spending some time reading the help documentation on index events if you need to become familiar with that. Reviewing your cohorts. So separate from propensity score matching features, but draws from the same starred characteristics feature from your doctors don't pay money late review. So looking back here, you can see these saved characteristics are selected from the available lists of demographics, diagnoses, procedures, medications, and labs, and they become the fundamental factors that are part of your propensity score model. So in this case, we chose overweight and obesity. This is, as I talked about last time, at too high a level, diseases of the nervous system from G00 to G99. That's incorrect. You wouldn't want to do that. You would want to pick something at a lower level in that hierarchy. Otherwise, TriNetX will select randomly anything from that pool, and that could include diseases that are wildly different from each other and wildly different in severity that could actually introduce confounders to your study. Same with factors influencing health status and symptoms and signs. So even if you see that the little signal icon, as we described last time, tells you that there might be a difference between the two groups, I would suggest not using it at this level of the diagnoses. You'll see here, as we talked about last time, you can dig in to very fine-grained definitions of some of these diseases, right? So you can see here we selected it at that top level, but really you'd want to go down to a deeper level here, other disorders of the nervous system or things like that. So your baseline I want to review your baseline statistics here. This will basically give you a t-test of comparing your different groups along these different metrics. So it'll tell you whether there's a statistically significant difference between your groups at age at index, between ratios of male and female participants, Hispanic or Latino, white or black, or any of the characteristics that you might include in here. So by starring these characteristics, they become part of your propensity score matching, but they also become part of your baseline comparison tool. Again, that t-test or z-test in this case is not as nuanced as your outcomes analysis because it doesn't include the process. Like there's no propensity score matching done here. It's just a comparison, a t-test comparison of these two to see if they deviate from expected probabilities. But they can tell you and help you understand whether you need to consider propensity score matching or if you should review your cohorts to exclude factors. You might find from looking at here that there is a statistically significant difference in BMI or A1C, and you may want to go back to your cohort to review them and make sure that your cohorts aren't apples to oranges and full of people with just higher BMI or A1C than the other cohort. Again, highlighting that when you star those characteristics to turn them on and off for your propensity score matching, you have to go back to this saved characteristics section and star and unstar them. Otherwise, they won't be removed from your propensity score analysis. Same here with the baseline analysis, as I pointed out earlier. And as I pointed out earlier, you can use this to preview your findings. But you won't have a time window or propensity score matching. As we described last time, propensity score matching plays the same role in our studies as randomization does in randomized control trial. That is, it is a function, a statistical tool that we can use to attempt to reduce bias in our studies. Now, it has some limitations compared to randomization, but it and there are some people who, people who work on stats really extensively and on the kind of mathematical models that underpin some of these things. And there are limitations to what propensity score matching can do. But it is well known, it's well understood as a methodology, and it's increasingly used to help um, ensure that there isn't bias from confounders in observational studies. Again, propensity score matching is available. You can run a simulation under where it says balanced cohorts. You can use the propensity score matching tool to turn these factors on and off and see how their inclusion or exclusion impacts your statistical model of the propensity score. And that can be something you can use these graphs to help you understand where the density or the overall total percentage of the cohort that is falls into these score categories where 0 is completely random and 1 along any given set of properties that you select for them, where 0 is completely 0 is completely statistically significant and 1 is completely random. No, got that wrong. Sorry. It's a propensity to be in a cohort. So 0 is random and 1 is that they have a high propensity to be in the score or in the category. So that's kind of a review of what we talked about last time. And now we're going to move to the more exciting stuff, which is the explore outcomes function. So once you have your cohorts all set up here, you will find that you've got your explore outcomes functions set up here, just like your doctors don't pay money late from the past. The only difference is there's no demographics here. So it's just don't pay money late because you can't change your demographics, right? You don't have people who change from black to white typically in their records. So they don't include that as an option to look at for outcomes, right? You can't have that. You can't have demographics become outcomes. So what this tool allows you to do is before you move on to the process of propensity score matching, you can load up a lot of different factors and load up your time frame and see how well your analysis does before you get into it. So it compares all diagnoses procedures. In fact, I'm going to turn it on just so you guys can see. I'm going to let it run for a moment. It compares all diagnoses, procedures, medications, labs in both cohorts against each other. So you can get a sense for if your outcome analysis is even going to have enough people in it to to function as an analysis. This is very common. We run into this where people are looking for very rare outcomes or things that don't happen very frequently, and they go through all the work of developing their propensity score model, only to find that the outcomes within those cohorts are either not statistically different at all, or they are not. There's no not enough people to draw any sort of conclusion. And you can check to see if you have captured all the right procedural codes and medications in your cohort definitions, because you'll find in here that if you look at the procedures, you might find, oh, we didn't realize that in addition to all of the codes that we had captured under surgery, we had not included these additional ones that everybody in our cohort seems to get. And that can be really useful. Same with diagnoses. If there are different factors in each group, you can see that our groups here are fairly well matched. I believe in this case, because they're fairly similar epidemiologically, like their health record is fairly similar. Their disease state is very similar at this moment that the study starts. So we can see that we have a pretty good matching for the two groups, and we have plenty of people in each of these disease categories that we might want to look at and zoom in on. So this tool is very useful for that kind of stuff, but again, not suitable for your final analysis, but it is a great way to find unexpected outcomes for your cohorts. And the found outcomes in your cohorts can easily be added to your final analysis. All you have to do is when you start this here, it'll save it to your outcomes. I know this is confusing because it looks like the saved characteristics that go into your propensity score model, but this is actually saving it to your outcomes page down here, where you can really easily select it from this menu. We'll come back to this in just a moment. You can add it to your study very easily. Yeah, so this is looking to the future. This is Marty McFly getting in his DeLorean and going to the year 2015 and confronting Biff Tannen and all that stuff. But this happens in starting from the day that people enter your study into the future of their health record as far out as it goes. Again, remember, doctors don't pay money late. That's going to be the framework here. And you're going to see these. Also, by the way, you can categorize your outcomes in your explore outcomes function. For diagnoses, you can categorize these by, or limit them rather, by acute or chronic conditions as well. So if you know you want to just weed out a lot of acute conditions here and stay focused on a small series of chronic diseases, that can be really helpful for that. And you can also you hit this little screenshot button here to get yourself a copy of this table and paste it into your notes so you can review it later on. You can also, there's a search box for this as well. So here we go. It's saving that graphic for me. But you can put in Alzheimer's here and search for your outcome. So that can help you find your findings a little more easily during the course of your study. And again, the signal and save tools function similarly, except that they go to your saved outcomes. Okay, we're here. We're at the time for running outcome stats. We've developed our cohorts. We've selected our covariates for our propensity score match. We've identified our outcomes. We are finally ready to find out our results. We've done all the hard work and we have arrived. So I want to give you 5 decision points that you're going to have to make to get the best analysis as you're going. And then we're going to review the stats available to you when you run this analysis. So let's talk about these 5 decisions. The first is to whether you're going to turn propensity score matching on or off. So by default, propensity score matching, if you go to your outcomes tab down here, it starts in the default off position, compare cohorts before matching. That means it's not going to try to use a statistical model like propensity score matching to try to do that. You have to turn it on by selecting the compare cohorts after matching tool. So propensity score matching, I'm going to say for almost all of the kinds of studies you're going to do in TriNetX, I would strongly recommend propensity score matching. There's almost no situation where you wouldn't want to at least control for some basic variables like age, right? It's very, very rare, unless you're doing like very specific age ranges, that you're not going to have a statistically varied, statistically significant difference between the two groups by age or ethnicity or anything like that. So there's almost always going to be some source of bias that you're going to need to use propensity score matching for. However, there are times, consult your local statistician or TriNetX expert, there are times where you might want to run your propensity score model off. Now, I want to just emphasize really quickly before we move on, this will make a little more sense later, but do not turn off propensity score matching in the quest to get more people into your study. That is not a good methodological approach, right? Do not turn it off so that you get the full people from cohort 1 and the full people from cohort 2 to be compared. Propensity score matching, as we discussed last time, will pull people, pull the the smaller number of people from the larger cohort to do a one-to-one comparison, a one-to-one match, right? So if you have 100,000 people in one group and you have 50,000 people in the other group, TriNetX will find 50,000 people in the 100,000 people group to compare one-to-one with the 50,000 people in the other group. Some, again, people who are just beginning or students who are starting out will say, well, no, I want all 100,000 people in my study. More is better, but that's not the case. In statistics, the signal to noise ratio, that is the number of random people in that pool, could distort your findings. So even if you have more people in your finding, right, more is not necessarily better. It can actually cause a lot of problems. So propensity score matching, you really have to think about whether you're going to use it, but most of the time for observational studies, it will make your finding clearer. Again, reasons to propensity score match. You have a large group of heterogeneous people, like 4 million type 2 diabetics. Those people are going to be wildly different from each other, right? You have lopsided cohorts, like one is very large, and the other has a very unusual disease state that makes them very small. You're going to want to make sure that you're pulling people from those two groups that allow you to do apples to apples comparisons that are meaningful, because the larger the pool, the more likely the law of large numbers is going to distort your findings. Um, Also, if you have identified confounders or demographic differences that need to be controlled for in your study, that's obviously going to be something you're going to do it. So, again, as I pointed out a moment ago, I got ahead of myself. Propensity score, a common mistaken thinking is propensity score matching makes my cohort small. Before matching my results, this is one, please do not do this. Before matching, my results were statistically significant. After matching, they're no longer significant. Maybe I just shouldn't use propensity score matching and just report my unmatched results. Do not fall into this faulty thinking. What this means is not, oh my gosh, I lost my 0.05, right? What this means is propensity score matching worked. If something is statistically significant before you use propensity score matching and then not after you use it, it means you've identified several important sources of bias that propensity score matching has neutralized for you and allowed you to see that ultimately, were it not for the influence of those factors, there would be no difference between your groups and outcomes. That's really important to know. Do not have what I call P blindness, right? The desire to get a P is less than 0.05 that sets you up where you're making faulty claims. And some people just say, like, I just really don't understand propensity score matching. I'm just going to throw everything into my model and it's just going to be okay. No, you can wind up with a model overfit, which distorts your data. So you have to use your theory, your knowledge of biomedical sciences, reading, talking to experts, using AI, all of these different things to help you construct a propensity score model that is effective. Okay, so that was my soapbox for that one. Decision two is going to be about time frame. It's very important in TriNetX and in all observational research to understand how time impacts your rate of outcome. So when we're going into the future, you can set this as far out as most records, I think, in TriNetX only go as far as 20 years. They found, I think, when they did an analysis that data more than 20 years out was very rarely accessed. So for the sake of parsimony, they just don't include it. When you're selecting a time frame, you really need to think about some stuff though. Depending on the study, the longer your time frame, the less likely that your outcomes are related to the index event that you're looking at. So does, for example, chickenpox or shingles cause people to develop Alzheimer's? Well, that one you actually probably want to have a fairly long timeline, right? But if, for example, a lot of times people talk about surgeries and looking at 10-year outcomes for surgeries. Well, there may be many cardiovascular surgeries that do have 10-year outcomes, but for a lot of like orthopedic outcomes and things like that, 10 years, after 10 years, the difference between these two groups comes out in the wash. And there are people who study exactly how much time. Things like cancer is usually done on 5-year outcomes, and things like surgeries are typically done on 90-day outcomes, right? Revisions after 90 days or infections within 90 days. But picking too short a time frame means that you might miss outcomes that are important. So you really have to think carefully. You have to think to determine the right time frame. You want to consider the type of disease or condition. As I said, cancers take much longer than infections to see an impact. However, some conditions can have years of impact, especially chronic diseases and depression or alcohol use disorder or liver diseases can take years and have years and years and years of outcome impact. Consider existing research. What kinds of timeframes are used in other studies? Like I said, 5-year clinical trial, a retrospective analysis that looked at 7 years, right, and pegged that as the optimal time frame. So use the existing precedents to help with that. I generally, though, depending on how you want to think about your study, I start with lifetime and then use the Kaplan-Meier analysis that we're going to look at in a minute to see if you need to zoom in. So we're going to talk about this, but a Kaplan-Meier analysis shows you after how many days, what percentage of people have had this outcome. And sometimes it kind of flattens out. And that tells you that after 5 years, no more of your people are having that outcome. For example, if we'll take a look at that in a moment. But the Kaplan-Meier tool can help you assess what a reasonable 5-year or what a reasonable outcome time frame might be. A pro tip is if you have multiple time frames, like for example, post-operative infection at 14 days, surgical revision within 1 year, you can just duplicate your analysis and change the time frames. Duplicating your analysis in TriNetX, you'll see that if you go to your My Analyses over here, you will see that you can duplicate these very easily, and you'll just be able to, you could call this 1 year outcomes or something like that. And you can also run them at the same time, so you don't have to sit and wait all day as it computes. Um, this can really help save time, and so you don't have to reset up two completely identical things and make sure you're checking all the boxes. Just duplicate it and change the time frame and change the outcomes. So another decision, index events. Are all of the characteristics of the index event of the cohort index events, or are some of the factors not part of the index event? So, for example, again, if you wanted to include people who had chickenpox, you might want to include people who had chickenpox at some point, at any point in their life. It doesn't necessarily mean that you have to wait until they've had chickenpox to enter your study, right? This can impact your outcomes by impacting when patients enter your study. If you go back to our last session, I went through a couple of examples of how that can impact things. So your index events, what is included as part of your index event, whether it is when they get when they're diagnosed with the disease or when they are given a medication. This can have severe impacts. This can also severely impact bias. This can introduce a phenomenon called the immortal time bias, where by selecting, for example, if you have one group of people who got a medication and one group of people who did not get that medication, but they were both diagnosed at the same disease, if you start the study when the people got the medication, the other group is just hanging around waiting to enter your study, right? There's a period of immortal time where they can't be kicked out regardless of whatever. So your outcomes that you would be looking at for those two groups might be unrelated to, it might just be related to the time dragging on between when one person enters your model and when the another person enters your model. So, for example, in our Alzheimer's and statins study, to solve the immortal time bias, we didn't start the study. One group got statins and the other didn't, right? So we didn't start the study when the people were given the statins. We started the study when they were both diagnosed with hyperlipidemia. That allowed us to have people enter at roughly the same amount of time without having to worry about whether one group was basically unable to be kicked out for that entire time frame. We're going to really quickly take a look at the outcomes window in your analysis. So when you are looking at one of your analyses, you're going to go down to here with outcomes. I'm going to turn on my propensity score matching. I've set it to 5 years. I've got my stuff going on here. Now we're going to look at those outcomes. As you saw earlier, I checked this box to include one of the starred outcomes for my Explore Outcomes tool. And this presents you with two important decisions when you're using this box. Decision 4 is your outcomes themselves. So when you are working on this, you can add more than one outcome to this, and TriNetX will pool those people. So, for example, endocrine diseases, but we could also add stroke, right? This would work where, for example, if you were trying to do MACEs, right? So you'd have major adverse cardiovascular events like infarction, heart failure, death, right? It's on TriNetX, you can find where there are death records available. They'll show up as death or deceased. And you can also find them under R99, which is ill-defined and no causes of mortality. I'm just going to take this out. So what we're doing here is because any of these are relevant to our outcomes in this study, we can pool them all here. However, you might also decide that you only want to look at heart failure, right? Pooling these because of severity, there could be many reasons that you might want to include outcomes together or not. Again, let's actually look at one that's very common is you could include depression and anxiety, right? Because these are two very comorbid psychiatric conditions. So including them both, there's actually depression comes in two flavors, major depressive and depressive episode. So you can choose to pool these, you can do them individually, but understanding how that impacts your analysis is going to be, and being deliberate about it is going to be very important to the validity of your study and the validity of your findings. You might find, and TriNetX won't tell you this, but you have to anticipate that some of those outcomes are going to be way more common than the others. And if you present it to people by saying, well, we looked at outcomes including MACEs, but really 90% of these are heart failure, or 90% of them are cerebral infarction, you're going to want to report that to people. So, have disaggregating and aggregating your outcomes can be really important in having an honest reporting of your data. So again, you can have, for example, in one of our studies, we did Alzheimer's disease, but we also pooled other degenerative diseases like Alzheimer's, Parkinson's, and unclassified or non-classified diseases of the nervous system because we wanted to see when you pool all of these together, do we get a better signal about the underlying relationship between statins and degenerative neurological diseases that we might be interested in. Just to be aware, you cannot use and connectors in here, only or. I'm not sure why. It probably has something to do with computer science and compute intensity, but you can only say that they had cerebral infarction or heart failure or deceased, right? You can't specify that they had all three of these things or more. You would have to go back to your cohort, define them as having had an infarction, a stroke before the start, and then include heart failure after that. So you'd be looking at people who had strokes, then heart failures as one of their outcomes. Um, so trade-offs again to single pooled outcomes. Single outcomes may underestimate your findings, right? You may wind up not including everything that you would think. But pooled outcomes can confuse your analysis since you can't see a breakdown of which people belong with which outcomes. And that leads us to decision five, exclude cases with prior outcomes. This is a very, very important box. It's extremely important to know what this does and how it works because it can impact your study. So, um, when you exclude patients with outcomes prior to the window, this is most of the time a pretty good idea, right? Most of the time, you don't want to include people. You want to look at, or many people are looking at, first time instance of type 2 diabetes, right? The first time they've been diagnosed with that after the index event. So you want to go and exclude anybody who'd already had type 2 diabetes in your cohort. So by checking this box, TriNetX will automatically exclude anybody with those characteristics prior to the start of your study, prior to their entrance into your study. Um, and we're going to talk about that this is an enormous time saver because then you don't have to go back into your cohort and exclude anybody with type 2 diabetes before your key index event moments. But there's a trade-off that comes with this. When you check this box, the TriNetX people informed me, and I thought this was very interesting. Um, as I was saying, sorry, you don't have to go back and redefine your cohorts. The TriNetX people informed me that the exclusion occurs after propensity score matching. So let's say you've got 3,000 people in one cohort and 10,000 people in the next. If you check that box, TriNetX will kick the people out of the cohort after matching them. It won't replace them. There's no replacement of those people. So that can actually substantially shrink your cohort. That means that I just did some quick math here. Let me go through this example. Your study included cohort one, where n equals 10,000, and cohort two, where n equals 1,200. Your PSM includes 1,180 people in each cohort after matching. One cohort has 500 people with outcomes prior to the study window, and cohort two has 300 people. After matching, you'll have 700 people in cohort one and 900 people in cohort two. So that's not necessarily bad because we're going to look at things by risk ratio and things like that. But if you redefine your cohorts, excluding the outcomes, you'd get those 900 people. You'd get, or your full boat of people that you could match into your cohort, and that would get you a higher chance of getting a more accurate count in your analysis. So by going back to your cohort, excluding people with your outcomes prior to the start of your study, there you'll save more people here. I'll tell you a little bit about where you're going to find this information in TriNetX to see if you should go do this. So if you have a small set of cohorts, excluding people post-match can really reduce your overall cohort sizes and mess up your numbers. One example would be like we looked at pregnant people with Huntington's disease in one study. And it's such a rare event that when we excluded people with outcomes prior to the window, we lost so many people that we really weren't able to conduct a good quality analysis. So we had to go back and define our cohort as people with Huntington's and who are pregnant and also did not have these following characteristics that are the outcomes we were looking at. So how would you know if you need to do this? Well, you can decide whether to use the exclude option or redefine your cohorts by looking at your outcomes window. You'll see underneath there's this little kind of opaque sentence here that will tell you a lot of information. In this case, I lost 835 patients from cohort one and 3,030 patients in cohort two because I checked that box that excludes people with outcomes prior to the window. And TriNetX did not replace them. So you can see I'm about 3,000 people short in one cohort than in the other. I guess a little less than that, 22,000 something less, right? Now, in this study, that's, 2,000 people out of 1,760,000 people. I'm not really losing a lot of sleep over that. Unless there was something very important about that pool of people, I think it's okay for right now until I go to do more precise numbers for publication to just use this function, right? But if you're having a much smaller thing, if your cohorts were 1,000 or 2,000 people, you might lose so many people out of your study that you actually won't be able to get an analysis at all, as I pointed out earlier. So that's something you need to think about. So we've looked at our 5 decisions and we're ready to run. You're going to hit that run button up at the top of the thing once you've got everything set up, and you're going to get some outcome stats. So exciting. We finally, after months of research and thinking and planning, we have our data. So we're going to go through the types of stats really quick, from propensity score matching to measures of association and the Kaplan-Meier curves and our number of instances. Going back again, we're looking at the propensity score match results just to give you a little more information about how to interpret them. This is the propensity score curves. They're not that useful, but they do help you get a sense for how different your 2 cohorts were before matching and after matching. You can see before matching, there were a lot of difference in propensity. That is the statistical likelihood of a person being in one pool or the other based on their characteristics you selected. And after matching, there's no real difference in that curve. So let's see what that actually means, because those graphs don't tell you the whole story. What you really need to look at is by checking the box that says p-value or standard difference. TriNetX will show you after matching what the composition of your cohort looks like and before matching. So in this case, I just want to zoom in here. Before matching, as I pointed out last week, there was a 13-year age gap in my 2 cohorts. So what I might have been seeing in my outcomes for my study was simply the result of one cohort being older and sicker than the other. But after matching, you can see, and let me just point out here really quickly, you can, when you read across this line, you'll see that the p-value before matching was statistically significant, which is bad. That means there was a statistically significant difference between the 2 groups and their distribution of ages, and that their standard difference was over 1, which means they are very, very, very statistically significantly different. After matching, the TriNetX was able to match them with people who are pretty close in age, such that their propensity, or sorry, their p-value, the difference between the 2 groups, is not statistically significantly different. No one group is that much older than the other group, and our difference is much below our 0.1 threshold that we want to have for standard differences down at 0.0004. That's good. So this means that the confounding factors associated with age may have been controlled for in our study. That's good news. Again, before matching, you want your covariates to be statistically significant. If they aren't statistically significant, there's some controversy over whether you should remove them from your model because they could cause overfit, or if you should leave them in because they are of theoretical interest, even if they aren't statistically significant between your 2 groups. I'd need a mathematician to weigh in on that one. After matching, you want them to not be statistically significantly different from each other. And counterintuitively, this means that there's no differences between the groups based on your factors, so they're balanced. One thing I want to point out again is sometimes you can wind up in a situation where even after propensity score matching successfully, your p-value is still statistically significant. Part of that is because the cohort, very, very large cohorts of people, can still be statistically significant, even with very small differences between them, just the way the math works out. So when that happens, check your standard difference to make sure that your standard difference is below 0.1. And if it's below 0.1, even if the p-value is still statistically significant after propensity score matching, you can be assured that your model has probably matched properly. and you can report those standard differences in your study. You'll see that right there. Okay. That is a review of our propensity score matching. We're going to jump ahead now to risk differences, risk ratios, odds ratios, and hazard ratios. Now, why? Because these are pretty fundamental statistical concepts that we're going to encounter throughout TriNetX, and people often don't fully understand what they mean, so they use them in weird ways. So let's talk about this. Risk difference is super easy to calculate, right? And it's best when you want to communicate absolute effect size of your two groups, right? So the frame is fixed, right? 30-day mortality, 1 year incidence. And your audience includes clinicians or policymakers who benefit from understanding how much extra risk is added or reduced per 100 patients, for example. That can be one way you can tabulate that. Now, a risk ratio is a very commonly reported version. It's an effect size, right? It's how much of an impact, a tabulation of how much of an impact uh, the analysis, the cohort membership means for your outcome. So this works when you're comparing the relative risk of an outcome between two groups over a fixed period, but the outcome is not rare and both groups are followed equally. And the reason that's important that the outcomes are not rare, meaning they happen more than 10% of the time, is that odds ratios can be a little more robust when things are rare. So when you have rare outcomes, generally under 10%, when the outcome is common, they can odds ratios can overestimate the effect compared to risk ratios, and risk ratios can underestimate the effect. So that can be something important to consider when you are doing that. You also, if you're using logistic regression to adjust for confounding variables, this can be useful to have odds ratios because it'll give you apples to apples comparisons. You also have hazard rates. So this is best when you're analyzing time to event data. Hazard ratios come from the Cox proportional hazard model where they're computed, and they tell you about how long it takes for an event to occur. We're going to talk about the concept of survival analysis, which is very confusing for a lot of people because the terminology gets in the way. We're going to talk about that in a second. But the outcome could happen at different times for different people, and you want to account for censoring in different follow-up times. So hazard ratios are really useful for temporal relationships. So risk ratios, when risk differences, when you want to communicate with people who maybe are non-technical. Risk ratios, when you want to communicate something that's a relatively common outcome, so it doesn't overestimate or underestimate that. Odds ratios, when it's something that's relatively rare. And hazards ratios, generally, when time is involved. So let's look at how TriNetX represents this for you. So let me take you through the math on this because it's pretty straightforward. This is like grade school math, right? When TriNetX computes for you, this is people in cohort 1 who had no statins, but no comorbidities either. 741,000 people were in that cohort when the study began, and 2,547 people developed Alzheimer's by the end of the study. Very small percentage, but again, we picked a very, very healthy group of people. So it's not that surprising that if you don't have a lot of Alzheimer's risks, you're not going to get a lot, you're not going to have a high rate of Alzheimer's, right? So it's fairly rare. So, but it's not super rocket science, right? 2,547 divided by 741,966 is roughly 0.343%. Very simple, right? So patients with outcomes divided by patients in cohort equals the risk percentage. I just really, by the way, the risk of outcome chart, I strongly, strongly recommend redrawing these charts with better sizing on the x-axis. In this case, probably something between like 0 and 2 or 5%, because you can see this is not a helpful graph, right? TriNetX generates these using an R package, and it just comes in between 0 and 100. I developed a tool for you guys to use to generate these kinds of bar graphs if you're not familiar with Excel. And so you can use that instead. But I strongly, strongly recommend redrawing those. Do not copy. In fact, do not screenshot and copy and paste any of this into any TriNetX screens into your posters or papers. We'll talk about this later. They look terrible. It looks very amateurish. Redraw things, create your own boxes so they print properly. And you'll see here it represents those percentages very clearly. Let's talk about risk ratios though, right? So your risk ratio is basically the risk of A divided by the risk of B, right? So if you divide 0.34 by 0.21, you get roughly 1.605. So that's pretty straightforward. That's the risk ratio, and that is the most one of the most common numbers that people use to report some of these differences. That means your risk is 160% or 1.6 times greater if you're in group one than if you're in group two. Okay. And let's talk really quick about risk difference. Again, you'll see that number over here, this percentage. It's risk A minus risk B. The statistical difference between groups A and B equals Z. So like a t-test, that's actually what this is over here, right? So it's looking at the percentages of these two groups and essentially runs a Z-test to determine whether this is a statistically significant difference between these two groups, whether that's by chance or not. And it'll give you your 95% confidence intervals. In this case, our 95%, we're 95% sure that our true risk difference is between 11 and 14, centering somewhere on 13. So please report that 95% confidence interval in your papers because it's one of the only ways that people can know how robust your findings are based on these reports. And again, odds ratios are pretty grade school math. Patients in cohort one with the outcome divided by patients in two with the outcome, divided by patient in cohort one without the outcome, and patients in cohort two without the outcome. So it's kind of just a different way of organizing it. And the numbers come out very similar sometimes, but again, it's more robust against smaller numbers. And you'll see here that they're very similar, 1.605 versus 1.607. So the drift between those two numbers is not that big, and the drift in their 95% confidence interval isn't that big either. You can see here 7,000, if you do the math, you'll get 1.607, which is exactly what we'd anticipate. So again, some notes on these. We talked about this before. Some people might be like, well, 0.13 is clinically meaningless. I mean, that's just like, one in 1,000 people who show up, right? Yeah, but at the population level, that's huge. That's a lot of people, right? If these numbers held true with 0.0013, it wasn't actually this number when we did our final numbers, but if you multiplied that by the number of statins patients who might be diverted out of the Alzheimer's risk stream, the lower risk of Alzheimer's is like 16,900 people, and that would reduce lifetime cost of care for those folks by $6.76 billion. And I'm sure we could all think of a good way to use that money for us. Now, that's a fraction, that's like 2% of all Medicare, but it's non-trivial. You could use that to end homelessness in America or something like that, right? Or provide better care for people who can't be diverted out of the Alzheimer's stream for one reason or another, through genetics or whatever other cause. So we could definitely just find some way to save that money and do something with it. And also, as I said earlier, most medical plans cover 100% of generic statins. It's no cost, low cost. The side effects are relatively low for a low dose, and people can be on them for a long time and tolerate them fairly well. There are some side effects, but you have to talk about that with your doctor to determine if it's a good idea or not. Also, there are otherwise very healthy people with no comorbidities for AD, and that's not exactly the natural group of people out there. So that's one way that I would address that to somebody who was criticizing the small pool from a clinical perspective, but we're not looking at a clinical perspective, we're looking at a population level. All right. So in addition to your measures of association that you can turn on here, you can turn on your Kaplan-Meier analysis and also check exclude patients with outcome prior to the window. Now, what does the Kaplan-Meier analysis do? So people usually call this a survival curve, Kaplan-Meier analysis survival curve. That name trips up a lot of students. Survival does not mean mortality. I had one student bring me a project. They're like, why do my people with like colds or flu vaccines keep dying in my study? I'm like, no, that's not what's happening. That means time to event. Survival refers to the absence of a particular outcome in a group of patients and how long, how many literal days. Like this is literally 1,000 days, a little under 3 years, I guess, from the start of the index event to when this occurs for people. So you'll see patients with outcome survival probability at the end of window is calculated pretty straightforward. It's just the percentage of this cohort removed from the 100%. That's the problem. Again, probability of not having an outcome. And here's your survival probability there. There's your days after index event. Percent of cohort without the outcome. Um, just to help make this a little more concrete for folks that might have difficulty with this, um, imagine I gave you four rocks, five rocks, and I told you to throw those rocks at these cans. And if you knocked out four rocks out of there, that means you have a 0% survival, right? That the event, getting hit with a rock, occurred within five rocks for 100% of your can cohort. And if you only hit two, then 50% of your can cohort would have been knocked over within the same five rock throwing period. So I know it's a little abstract, but just think about it as how many people are left unaffected during that time frame. So here we go. I knocked out these three cans. So in five throws, I knocked out three. 75% of the cohort. Survival rate of 25%. The graph shows the percentage of people without the outcome over the number of days. And here's a real world example from a TriNetX study that looked at aspirin, histamine antagonists, and aspirin in COVID-19 patients. And you can see, as I was talking about earlier, the impact of the intervention was very strong up to about 100 days, right? 80, 90 days out from that initial study. And then you can see this flatten out. What's useful about this graph is this can tell you like, well, it's not really that useful to continue out to 300 days because after 300 days, famotidine and aspirin may not be making much of a difference. And we might actually get confounding from other external variables like clotting disorders or other things that might not be at all related to our outcomes of interest. So you may consider that it's worth cutting your study at like roughly 90 days here and capturing the bulk of the people who are likely related to your outcome. Now, you can, if you are not scrupulously honest about it, wind up cloaking further outcomes or other kinds of things. So you may want to choose to just go with 365 days or 5 years or whatever. Anyway, but you can use the Kaplan-Meier analysis to dial in your study length a little more carefully. You can see here that first 40 days is quite a doozy. After 180 days, almost nothing happens. So you can probably cut the analysis at 180 days in this case if you wanted to be conservative, or you could compare the hazard ratio at 40 and 180 days and see if there's much difference. So let's just go really quickly through what it gives you, what this gives you. The first is the log rank test. This analysis will tell you the chi-square, the consistency of your outcomes. That gives you a nice p-value that tells you whether it's likely that these values come from the same distribution or not. It's always going to be one when comparing two cohorts, right? That's the best possible number. Or sorry, the degrees of freedom is always going to be one because it's n minus one. In this case, 2 minus 1 is 1. And the p-values testing that null hypothesis. The survival curves are the same for cohort 1 and cohort 2. The alternative hypothesis is that the survival curves are different between cohort 1 and 2. In this case, we can reject the null hypothesis because it's statistically significant. Okay, hazard ratios, really important. Comparison of the hazard rates between two cohorts. The hazard rates refer to the rate at which patients in the cohort experience an outcome for the first time. This compares how quickly two groups of people experience an event over time. If the hazard ratio is 2, it means one group is experiencing the event at twice the rate as the other group. So please pay attention again to your 95% confidence interval and pay attention to the difference in what risk ratios and hazard ratios report in terms of rate versus end of the day, end of your study amount. The test of proportionality is really important. This tests to see if the hazard rates follow the same trend over time and differ only by the constant factor that you're looking for. So basically how likely the two trend lines are to differ by that factor. It's a significance test for it. If it's violated, if it's a statistically significant outcome, it means that there's some other factor influencing these outcomes over time than the ones that you are looking at. Proportional hazards, the not significant test, proportional hazards assumption holds, and hazard ratios are constant over time. That's one of the assumptions of the Cox proportional hazard ratio is that you don't wind up with more risk over time. However, that can happen with stuff which is the longer you live with a heart defect, the more your risk accrues over time. All right. Just to make things more confusing, there can be a time where survival means life or death. That's when your outcome is being deceased, right? So in this case, in our cohort, 9% of people in the no statin group died in the first during the study period, and 7% died in the statins group during that time. And then here you can see, over time, this is the percentage of people who are dying, and you can see these factors. Now, the proportionality assumption is violated, likely because this is attributable to your population just being 3,500 days older. That's 10 years, right? So if your study starts when your average person is 65, they're 75 when it ends, and their actuarial rate of mortality is increasing every year anyway. So you'll see that over here happen in this way. And even if it's that's a pretty robust hazard ratio, but still. Okay, I want to close out this little section on the number of instances test. Setting it for date causes it to include each date of occurrence as an instance. This tool basically tells you how many times the event you're looking for, your outcome, shows up in the study, in the patient's record. So setting it for that date again is every day that it occurred. So for how many days the person was on antibiotics, how many individual dates over here versus how many visits. Like, for example, if they had 5 visits where they were given antibiotics in a 14-day hospital stay, that would be more likely to show that. And you'll get a graph like this that shows you, the percentage of people who had one event or two or three or four or more in your group, and whether there's any statistically significant difference between them. This is better for things like medications and procedures, but I usually don't use this tool for very much. You can use it for certain advantageous situations, but it's really not that useful in some ways. Um, so at the end of all of this, once we've done this, to what degree do statins impact people's odds of developing Alzheimer's disease? Well, our null hypothesis is that it's not associated with any changes in likelihood of development of Alzheimer's disease. That's false. It definitely is impacted by that. And statin use is associated with a lower likelihood of developing Alzheimer's disease. And time on treatment impact, that's something we had to do in our study was before we published it, was look at time on treatment and dosage impacts. But we were able to do that pretty effectively, looking at high and low dose statins. Okay, so we've gone through all of the major stats that the compare outcomes function, which is the major tool in TriNetX that most people use. And, it gives you some pretty good information about it, but we got to assess our validity. So one way we can communicate our validity, in addition to having a strong study design and a range of different stopgap measures and sensitivity analyses, to do that, is to communicate things using Cohen's H effect size. So it won't work for binary characteristics like male or female, where you would use your standard difference for analysis, but it will work when you have a continuous variable like BMI or age. And it just means you just need the means of each group. I'm sorry, the H will work if you have a dichotomous variable like had type 2 diabetes or not. So the p-value is significant. If you run Cohen's H on your factors, it will tell you how significant, right? So an H of 0.02 is small, 0.05 is medium, 0.08 is large, and an H larger than 1 is very, very large, a very large effect size. And generally, things greater than 0.4 or 0.5 are considered relatively robust and worth reporting. An alternative tool you can use for this to compute, you have to compute this separately outside of TriNetX, but is the E-value. It's a sensitivity analysis metric for unmeasured confounding on the risk ratio scale. And larger values indicate that a stronger unmeasured confounder would be needed to explain away the observed association. So TriNetX doesn't compute it, but the TriNetX publication toolkit that I'll show you guys later will compute it based on your findings. So just as an example, if your E-value is computed to be 3.41 based on your analysis, it means that you would need to find some unaccounted for variable that is greater than 3.41 times the impact of your study to undo your finding, right? To explain away the observed association. So that's really useful for being able to identify how confident you are in the idea that your analysis has looked at and found a stable association. E-values are pretty cool. I just want to review before we go, outputting your stuff to a Word document. Because the data in TriNetX changes. It's like the ocean, right? You have data coming in and out from different pools all the time. And so you might run the same analysis on 2 different days and get slightly different results, right? I strongly recommend once you have completed your analysis and you're ready to start writing it up, that you were either Word doc or Power actually you probably should do both. Export both a Word doc of your outcomes and um, CSV files of your outcomes. So when you press this button in TriNetX, it says export all on your results page. Um, I'll run this, but you can see the button is located right here next to the run button on the results. I'll just, oh, I must have forgotten this. Just give me one moment. Oh, oh, yeah, there we go. Gonna run that while we're talking. You'll see an export all function under results. And what that will allow you to do is select number one, your measures of association and your Kaplan-Meier analyses and anything else in this, and to export it as both a table and a graph, and conversely to export it as a Word document. I recommend always getting yourself a Word document version of these tools because it does a very good job of outputting all the relevant components of your study. You could give me your Word doc version and I can rebuild your study in TriNetX. And we'll also talk about next time downloading individual files and what that's useful for. But the report makes it easy for you to send your results to mentors and partners for evaluation. You can save them as a snapshot of your study for use later, and you don't have to keep referring to the website and logging in and navigating to your page and all that kind of stuff later on. It's pretty useful that way. What's included in the Word doc? Outputs of all your criteria for your cohorts, demographics, diagnoses, labs, medications, your logic, you can see here, these are all of the exclusion criteria we had. Um, It'll output your risk analysis into a nice little table like this that you can review later. And it preserves your recipe for your study, the characteristics that you used in it, in Appendix A through C, which includes basically all of your ICD-10 codes and your drugs and your procedures and everything like that. So this is an extremely useful way to get a snapshot of your study in just a minute. And again, you can download by using the individual files function. You can download your data as individual CSV files that you can use, for example, my TriNetX Kaplan-Meier survival curve tool to draw for you. You can drag and drop it in, and it will redraw the curve for you and allow you to manipulate it in a much more detailed way than you would in TriNetX. And I'll talk about this a little more in session 6. Okay, that's all I got today. Next time, we're going to look at the Cox proportional hazards model and time on treatment and treatment line tools. And we're going to find out a little bit about how these tools can help to give you more specifics as you write up your manuscript there. So I'm going to end the recording and share this out by YouTube coming up. Thank you for joining, and I'll take any questions now if anybody's got any thoughts.